I'm actually up next, and my charge from Dave Dawson was to talk a little bit about how to build a carotid intervention program, talk about some of the requirements and the nice-to-have things. And I do serve as an advisory board member and a consultant for a couple of the companies that make carotid stents. So a few things I wanted to mention up front. Dr. Moore said that he didn't think that the CREST trial had changed much, and I think it probably has changed a few things. One is that the FDA advisory panel actually voted in favor of broadening the indications for carotid stenting, in large part due to the findings from the CREST trial, and I know that Christian will probably talk a little bit more about this in his talk. And there was a very recent now publication of the newest guidelines regarding the treatment of extracranial carotid and vertebral artery disease, and I think there are some important changes in these guidelines based on the results of the, probably based on the results of the CREST trial. I'm not going to spend a lot of time on this, but I thought I would just show you a few of the highlights from these guidelines. This is a very comprehensive document, 80 pages long, 748 references, a very thorough review of the body of knowledge regarding extracranial carotid artery disease and vertebral artery disease, and really an unprecedented collaboration between multiple societies, a remarkable alphabet soup of societies involved in the writing and development of these guidelines. So like most of these guidelines now, fairly standard in terms of how they present a classification of recommendations and the level of evidence. Classification is based on the size of the treatment effect, class 1, for where there is a clear, appears to be a clear treatment benefit and that the procedure should be performed if appropriate in a given case. Class 2A, when there is perhaps less of a treatment benefit but still an apparent benefit, so it's reasonable to perform that procedure or give that treatment. Class 2B, where there's perhaps a slight benefit of that treatment, so that treatment may be considered in appropriate circumstances. And then a class 3, where there's really no treatment benefit or perhaps harm from a given treatment or procedure. And then the level of supporting evidence, strongest being level A down to level C. And this has become sort of the standard way now of reporting out these guideline recommendations. So if we look at the recommendations from this hot off the press document, and first looking at the recommendations for selection of patients for carotid revascularization, class 1 indication, really for carotid endarterectomy, the recommendations have not changed, but there's now a class 1 recommendation that carotid artery stenting can be considered as an alternative to carotid endarterectomy for symptomatic patients at average or low risk of complications associated with endovascular intervention when the appropriate anatomy is present and lesion severity is present, with a level of evidence of B. So I think that's an important change and likely is a reflection of the results of the CREST trial. In terms of asymptomatic patients, it's felt to be a class 2 recommendation that carotid endarterectomy could be performed in asymptomatic patients who have more than a 70% stenosis in the internal carotid artery if the risk of complications from surgery is low, with a level of evidence A. And also that it's reasonable to choose endarterectomy over carotid artery stenting when revascularization is indicated in older patients, making the point that Dr. Moore just did in his presentation. But very importantly, class 2A recommendation that it is reasonable to choose carotid artery stenting over carotid endarterectomy when revascularization is indicated in patients with neck anatomy unfavorable for arterial surgery. So high risk due to anatomic criteria with a level of evidence B. And that's a significant change, and that I think perhaps is the first step in the broadening of FDA approval for carotid stenting, and perhaps the first step in ultimately having CMS change their non-coverage policy with regards to stenting for these indications. So getting back to the topic that I was assigned, carotid program requirements and the nice things that are nice to have if you're starting a carotid stenting program. Well, I think it's been very well shown over the years in multiple different studies and venues that the skill of the interventionalist is critically important with regards to outcomes with carotid artery stenting. There is a significant learning curve. We've seen that over the years in the multiple trials that have been done. It's also very important to have an experienced team in place at that hospital, both on the floors as well as in the endovascular suite or cardiac cath lab. Need to have high quality imaging. Need to have adequate procedural volumes to support that program, because again, it's been clearly shown that like with many cardiovascular procedures, outcomes are significantly associated or tied to volumes. If you're going to be performing carotid stenting on Medicare patients, you need to have CMS center approval, and you need to have data outcomes reporting. Most commonly now this is done through either the ACC or SVS database system. And then for most programs to be successful and to have volume, you have to have post-market approval studies in place so that you can treat many of the patients who come in with carotid artery disease. If you're performing carotid stenting in your hospital, you should absolutely have pre and post-procedure neurologic assessment in all of your patients. And the minimum that should include an NIH stroke scale. Now, it does not necessarily have to be done by a neurologist. People can and are being trained to do these NIH stroke scale testings, can be physicians, nurses, or in some cases, research coordinators. Of course, you need to have the full inventory of equipment, embolic protection devices. We'll talk a little bit more about that. And ideally, you should have neurorescue capability in your hospital for those rare cases where you may have a significant peri-procedural or procedural stroke. I would say the nice to have is multidisciplinary collaboration, being able to work closely with colleagues in other disciplines to benefit from their viewpoint and their experience, an extra set of eyes or hands. I would say it would be nice to have neurology participation in the program. I think in many places neurologists are not very interested in carotid stenting. In many cases they don't believe in revascularization for asymptomatic patients, so it's hard to get them involved. And I think if you're doing high volume of carotid stenting, it's nice to have skill and capability with both proximal and distal embolic protection devices, because there is now a body of evidence evolving that these proximal protection devices may be more effective in symptomatic patients or recently symptomatic patients. We've mentioned already about the importance of the learning curve, experience, and physician and center volumes. This is a registry, a very large registry from Germany of over 5,000 carotid artery stenting procedures over a significant period of time, showing first the importance of the learning curve with outcomes improving significantly over time from the early years to the more recent time frame of 2004 to 2005. Also showing the importance of center experience, basically the volume within that hospital, with centers doing only 1 to 50 interventions having a significantly higher stroke or death rate than those who have performed interventions or a number of interventions over 151. And then also for the interventionalist, clearly volume is important, and in this case the best outcomes are achieved in the really high volume interventionalists who do more than 50 interventions per year. The importance of the team cannot be underestimated. Having the appropriate equipment for you for your cases, making sure that the appropriate equipment is available, monitoring anticoagulation during these procedures. It's important to maintain an ACT of above a certain level, particularly with some of the embolic protection devices. Appropriate management of blood pressure during the procedure. This can be a very important aspect of the procedure. Anywhere from 10 to 20% of patients can have significant hypotension after placement of the carotid stent and post-dilatation. And rapid and appropriate treatment of that hypertension can be critically important. There needs to be rapid availability of adjunctive pharmacologic agents. Atropine for those patients who have significant bradycardic response to the carotid dilatation. Pressors, as we talked about, my nurses will have a syringe of Levophed available, so I can give small boluses of Levophed to bring the pressure back up quickly. And then we'll have niacin available for IV infusion when necessary. And also have to have quick availability for TPA if you have an embolic complication from your procedure. We have our nurses monitor patients during the procedure, the very simple thing of having them place a squeeze toy in the patient's right and left hand to monitor them, but also asking them questions during the procedure to get a sense for how the patient is doing. And then, of course, the very important post-procedure care, particular monitoring blood pressure after the procedures in those patients that are hypertensive or hypertensive, trying to avoid hyperperfusion syndrome, monitoring and making sure that they get their appropriate anti-platelet agents and monitoring them for any potential groin or access site complications. Can't underestimate the importance of good quality imaging. I don't think that it's really appropriate to be doing these types of cases in a cardiac cath lab where you don't have digital subtraction imaging, nor do I think it is optimal to be doing it in an operating room where you have poor quality imaging with some of the C-arms. You need to be able to see those embolic protection devices to monitor their position in the distal internal carotid artery. If a patient has an event, a small stroke, sometimes the findings on the cerebral angiogram can be very subtle, so you need to have good quality DSA to check for any abnormalities and to help guide any possible neurorescue procedures. As we talked about already, you need to have CMS approval of your facility to perform carotid artery stenting. It's not actually a very difficult thing to obtain, as you can tell by the fact that there's now over 1,200 facilities in the United States that are CMS approved to perform carotid stenting, and actually over 100 of them in the state of California. You do have to recertify every 2 years. The site must submit an affidavit to CMS stating that they continue to meet all of the CMS facility standards, basically physician training standards, facility device inventory and support, and then data collection to evaluate outcomes. So you usually need to participate in one of the national registries, either through SVS or ACC. And you must be able to submit the specific data elements to CMS regarding your outcomes. So as we talked about, the ACC has their NCDR registry, the National Cardiovascular Data Registry, for carotid stenting and carotid endarterectomy. We do participate in this registry. The Society for Vascular Surgery also has their own registry. And either one, I think, would be appropriate for helping to maintain your data. I think we're all aware of what the FDA approval for carotid stenting was back in 2004. Basically, the FDA approved stenting for high-risk patients, basically patients who are higher risk for complications from endarterectomy and had symptoms, hemispheric symptoms, with greater than 50% stenosis of the common or internal carotid artery, or if they were asymptomatic, they had to have greater than 80% stenosis of the common or internal carotid artery. But something that was relatively unprecedented at the time, CMS decided to base their reimbursement on something completely different and did not base reimbursement on the FDA approval for carotid stenting. They basically decided to only reimburse high-risk symptomatic patients with greater than 70% stenosis of the internal carotid artery. And so if you're treating patients only based on CMS reimbursement, that's a very small slice of the carotid stent population, probably around 10% or less of the patients that we see with carotid artery disease that we're thinking about performing revascularization on are high risk, symptomatic with greater than 70% stenosis. So if you want to treat some of these other patients and be reimbursed and not get yourself in trouble with CMS, you have to participate in some of these carotid post-market approval studies. And at UC Davis, we're currently participating in 2, the Sapphire Worldwide Registry, which uses the Cordis platform of the AngioGuard embolic protection device and the Precise stent. And we are participating in the Abbott-sponsored CHOICE study, which allows you to use either the AccuLink and AccuNet embolic protection device or the NAV6 protection device with the exact stent, or you can mix and match. And it allows you then to choose potentially from an open cell stent platform or a closed cell stent platform, which may be appropriate in certain types of cases, particularly symptomatic patients. You need to also have the research infrastructure if you're going to be participating in these clinical trials. And again, we're fortunate to have some very talented research nurses and coordinators at at UC Davis, and these are a couple of our research nurses, Janine Carlson and Kim Book, who were in the cath lab with us during one of the carotid procedures. Goes without saying that you need to have all of the appropriate inventory to get yourself into and out of trouble, the appropriate sheaths and guiding catheters, guide wires, embolic protection devices, ideally both proximal and distal. Carotid stents, as we talked about, it's nice to have both open and closed cell stents available to you, as well as the straight and tapered configuration. And then bailout equipment. For those very rare cases where you run into a big problem, it's nice to have neuro rescue capability, little micro catheters that you can deliver into the cerebral arteries for local delivery of agents such as TPA or 2B3A inhibitors, and potentially some of the retrieval devices like the Mercy concentric device, which is approved for the treatment of acute stroke. This is just an example of a patient who had a very large embolus to the M1 segment of the right middle cerebral artery, potential for devastating stroke with a situation like this. Microcatheter was placed in the M1 segment of the MCA, low-dose thrombolytic infusion was initiated with restoration of patency. And in this case, it was not one of my cases, but complete neurologic recovery. As we talked about, multidisciplinary collaboration is, I think, a very nice thing to have in your institutions. Certainly there are many places where physicians are going it alone without help from their colleagues, but it's, I think, very helpful to have different disciplines involved, different opinions, different viewpoints, different sets of eyes and hands in these cases. It's important to have people watching your back if you get into trouble. It's nice to have that on your side. This is actually a case that we did live a couple of years ago. It's Bill Pevick, myself, and Jason Rogers. A very challenging case, a patient of Bill's that we worked on together who'd had a previous endarterectomy, had restenosis, but also aneurysmal degeneration of the carotid artery, and we worked together and deployed a stent graft in this case with a successful outcome. So in summary, I think the important elements are an experienced team, full inventory of equipment, adequate procedural volumes, CMS center approval, and as we talked about, outcomes reporting in one of the national registries. With that, I'll stop and thank you very much for your attention. I'm actually up next, and my charge from Dave Doss, a few things. One is that the FDA advisory panel actually voted in favor of broadening the indications for carotid stenting, in large part due to the findings from the CREST trial, and I know that Christian will probably talk a little bit more about this in his talk. And there was a very recent now publication of the newest 148 references, a very thorough review of the body of knowledge regarding extracranial carotid artery disease and vertebral artery disease, and really an unprecedented collaboration between multiple societies, a remarkable alphabet soup of societies involved in the writing and development of these guidelines. So like most of these guidelines now, guidelines regarding the treatment of extracranial carotid and vertebral artery disease, and I think there are some important changes in these guidelines based on the results of probably based on the results of the CREST trial. I'm not going to spend a lot of time on this, but I thought I would just show you a few of the highlights from these guidelines. This is a very comprehensive document, 80 pages long. 7 was to talk a little bit about how to build a carotid intervention program, talk about some of the requirements and the nice-to-have things. And I do serve as an advisory board member and a consultant for a couple of the companies that make carotid stents. So a few things I wanted to mention up front. Dr. Morse said that he didn't think that the CREST trial had changed much, and I think it probably has changed